Steve, look at that background. Look at that.
Yeah. Yeah.
Thank you so much for joining us, all three of you. Dr. Anna Malinow, we had Friday night, so you may recognize her. Kay Tillow, and Steve Grumbine, who gave me my start in this crazy live stream, career, if you want to call it, almost 5 years ago. So always great to see you, Steve, as well. So the way we're going to do this panel is we're going to give each person an opportunity to share their thoughts. Then we're going to open it up for a discussion and go from there. So, Dr. Malinow, if you'd like to go first.
I think that Kay is going first.
Oh, I apologize. You're right. Kay, if you'd like to go first, and also, please introduce yourselves more thoroughly than I can, because you have a lot of credentials, all three of you. So before you speak, please let the audience know. But yes, Kay, take it away. Thank you.
Thank you. I'm excited to be here. I am a retired union person, spent my life working in the union movement, mostly with healthcare workers and with nurses. And that's how I ran up against our non-functional healthcare system, which didn't treat the workers right at all, nor the patients. And I have now been working for about 30 years on trying to bring national single payer to our country. And I did a lot of work in getting unions to endorse national single payer, HR 676, which was the bill at that time. We got over 600 unions, including, I think it was 44 state AFL-CIO federations in support. So that's some of the work that I'm happy to be doing. But I'm glad to be here and to talk about this really, really important issue, because we have to get it right in order to make it happen. In the time that I've been working on single payer, we've had 2 go-rounds where it seemed possible that we could get healthcare reform. The first one was in the early 90s, and that was during the Clinton administration. There was a strong single payer movement. We did tours across the country. Here in Louisville, Kentucky, we wrapped red tape around the Humana building and talked about the administrative waste. And we ended up with Hillary Clinton proposing a plan that kept the insurance industry in, turned everything over to HMOs. And we were told at that time that we have to do this because your single payer plan is not feasible, and this one is, and we're going to be able to do it. The reality was that they couldn't even get that to a vote, and that opportunity for healthcare reform slipped away. The second go-round was during the Obama administration in 2009, 2010. And Obama, who had promised in front of the Illinois AFL-CIO that he was supporting single payer, ended up, when he was running for president, not supporting single payer, and indeed supporting a plan in which he included all the insurance industry and all of the pharmaceutical companies, making everybody happy, and bringing us a plan called the Affordable Care Act, which I will refer to as the ACA. Each time we get close to healthcare, they impose something else in between, and they assert that the plan that they're imposing is going to do exactly what single payer would do, except it's feasible. And I contend that what they impose is always a plan that maintains the profits in healthcare. And indeed, it's the profits in our system, the profits in the insurance industry and the hospitals and nursing homes, the for-profit industry, that makes it not work, that makes it cost so much, and that produces the barriers that keep us from getting to the care. So that's the key thing we have to look at. If there's profit in it, it won't work. If there's profit in it, there will be barriers to care. And that's because there's a basic contradiction between a profit-based system with insurance industry that is, under US law, responsible for producing the biggest profit possible for its stockholders, and the interest of the patients who get denied care because that produces more profit. The insurance companies have put in all of the barriers to care, the co-pays, the deductibles, the pre-authorizations, the narrow networks. You go down the line. Everything in the way of getting care produces additional profit. So it's the profits that have to go. The profits in healthcare are diametrically opposed to the interests of the patients, the interests of the people, the interests of the nation. That's what single payer has to do. Remove the profit-making insurers, the profit-making nursing homes, hospitals, etc. So what we find in addition is that they tell us, well, you can't do single payer, but you can do little tiny steps and somehow we'll get there in the end. We're going to take tiny, tiny steps and we're going to get to single payer. And the problem is none of those tiny steps help us in any way to advance the cause of getting to single payer. You may do something that helps some group of people, but you won't take out the for-profit system that is denying the care to the nation. And there are many of these incremental steps that are proposed. They propose expand Medicaid, patch the Affordable Care Act, improve Medicare by adding glasses, dental, etc. That might be a good thing, but it won't get us closer to single payer. And then there's the proposal for the public option, which everybody was for, and then it went away. But the reality is the public option or a Medicare buy-in doesn't do it for us either, because you will then have a public plan operating in a market-based system. And I think the closest thing that we have for showing what will happen if we do the public option is what we're experiencing now. We have the Medicare Advantage plans that are the private Medicare plans that Joe Namath is selling them. I'm sure you've heard it. And we have traditional Medicare. And we see that this public plan operating alongside of the private plans doesn't fare well. It ought to. Medicare has a 2% overhead, the private plans at around 15%. But it doesn't do well because there's no such thing as a level playing field. The insurance companies cherry pick. That means they get the healthiest people into their plans. They're more profitable. They lemon drop. They remove the patients who are the sickest and they get thrown back onto the traditional Medicare, and they cheat. They upcode, which means that they pretend patients are sicker than they are. They increase the money that comes to them. We've overpaid Medicare Advantage in the last 12 years by $140 billion. We can't leave them in. The for-profit insurers have to go. We cannot incrementally get to this solution. And I think that the solution that is proposed by many people, we need to deal with as well. And that is that we should do it state by state. That is more difficult, I think, difficult for us to handle, but we need to know the truth about it. So let me lay out the case that those who advocate the state-by-state system make. They say it's too hard to win Medicare for all nationally. So let's do it a little bit at a time, win one state, then everybody's going to see how well it works, and they're going to want it too, and so there'll be another state and another state. Eventually, we'll have the whole country. The nation will finally see it, and then they point to Canada and say Canada did it in Saskatchewan, in one province, and then others did it, and it became expanded to the whole country. Well, let me just start with Canada. Number one, when Canada did their Medicare for all, they did not have any national healthcare programs. Healthcare was a provincial responsibility. In our country, we have a multitude of national programs already in effect. 60 million are in Medicare, close to 80 million are in Medicaid. There's many millions more in the federal health insurance, in the federal health insurance plans, in others like the Indian Health Service and the VA, etc. So the basic premise of single payer is that you get the funding into one stream, you cut out the profits, you have a public funder in one stream, you simplify, and therefore you save the money in administrative costs and profits that allows you to use the money to make everybody's health care better and to extend it to those who don't have coverage. Well, if you can't get it into a stream because it's controlled at the federal level and the state doesn't have access to it, you can't do it in the state. And that's the problem. You can't get Medicare money into the state. There's no such thing. I mean, the people say, well, we'll just get a waiver. Well, there is a waiver that people can get for the money that's in the Affordable Care Act. That can go to the state. It's a section of the law that says that. But there's nothing that gives Medicare money to the state. And it's a problem that we shouldn't try to solve by busting up Medicare and turning it over to the states. So that's one of the big problems. That's why many of the people who advocate actually for state plans still say they can do quasi single payer, or they put single payer in quotes. This is a pathway to single payer, because the reality is, and many people working on it don't know, that you can't do bona fide single payer in one state. You can't get the funding into one stream. There are other problems that are involved as well. Another one is something called Erisa. And without getting into the woods on that, it's a federal law that says the Congress, the national government, has a right to make the laws that govern employer benefits and employer health care, et cetera. And states can't make laws about that. So those laws basically are blocking the ability of a state to control what employers do, even to tax in a way that they might be able to raise the money. So Erisa is a huge problem, in addition to the Medicare problem, for you to try to do a state plan. And then I think we should also look at what happens if the money gets allocated to the states, and if we could do it one state at a time. And let me just take you through what's happened with workers' compensation, which I'm familiar with because I've dealt with it over and over. The taxing system is different state to state. Workers' comp, while it's a federal, the states determine the taxing. And that has led us for states to fight each other over who's going to get employers to locate in their state. In trying to attract jobs, one state after another says, well, we have to lower the workers' comp because the tax rate's too high, and we get into a race to the bottom because we're in a fight because the rates are different in different states. I think if you look at not only workers' comp, but we can look at a couple of other things that are really, really important that we can't leave to the states. Look at voting rights. It doesn't help us to get voting rights in Illinois if you can't get voting rights in Georgia. It it doesn't do it. You have to legislate that on a national scale to actually make it just. And we can also look at reproductive freedom. You know, we're now going through a situation where the right to get an abortion is threatened throughout many, many, many states, and state by state can't fix it. We have to fix it nationally. We need national legislation that's going to put that in place, and that's what we need for healthcare as well. We, in many ways, kind of a states' rights plan is a backward plan, and it's always played that role within our country. So it's not good to divert federal money to the states, and it's not good to break up Medicare. And I think that one of the biggest difficulties is that states, in trying to do single payer, and I don't doubt the good intentions of many of my friends who are working on those state plans. But the problem is, because the barriers are greater on the state level than they are on the national level, they are likely to lend credence to the assertion that single payer doesn't work, because in fact it doesn't work state by state, and it doesn't work in one state. And I think there's one more thing, and that others will talk about. The funding is more difficult. States are have regulations that they have to balance their budgets, and you have to balance the budget. You're going to have healthcare fighting against education and a lot of other problems with being able to fund it on a state basis. So what I would encourage people to do is come together and talk about how we can do it on a national basis. And because you see, some people have gone so far as to say, well, we should drop it nationally. It's not going to happen nationally until you get several states. And that sets up a precondition that we can't accomplish, and that means we never get there. So I think we can say, yes, it's difficult to do this on a national basis. Nobody's saying that this is easy, but it's much easier if we could get everybody in line and working on it and continuing to press for it and building the support. We indeed have majority opinion within our country, which many people have been working on for years. There's majority support for this idea. We have to help the people to understand that the profits have to be removed, that we can't make a compromise on leaving the insurance industry in. That will destroy our ability to get it done. And I think we recognize that we pay more than double per capita what other nations spend, and we're not getting our money's worth. We are 4 years behind in life expectancy. We've suffered more than other nations through this pandemic. And it really is the time to rally our people around getting a bold and beautiful plan that combines what we know in terms of the data and the research with a movement that is strong enough to make it happen. They'll try to impose in front of us an insurance-based plan, but we'll be ready for them, and we'll have the experience and the understanding to make it happen.
You are so right. Everything co-sign. I just want to say it's so incredible that, some of our panelists Friday night and you and so many others, you have been doing this for 3 decades. Like, I am not ashamed to admit I got my free education in 2015 with Bernie Sanders, as many of us did. Like, it took me till my late 30s to realize just how bad this is. So props to you. And you have touched on something so important, that if you take, women's rights state by state, if you take, even civil rights state by state, if you take Green New Deal state by state, This is incrementalism. That's what this is, and it doesn't help everyone. And you are so right. You nailed it. Dr. Malinow, you are up.
Thank you, Joy. And you know what? It's never too late. So I'm so happy you're here. So yes, my name is Anna Malinow. I'm a retired pediatrician from University of California in San Francisco. I've been a pediatrician for almost 30 years and just retired in December, so very recently. I am past president of Physicians for a National Health Program, and that's an organization of 25,000 physicians that and health providers that support national single payer. I am also the co-founder many, many years ago, like over 2 decades ago, of Healthcare-for-all Texas, also Doctors for Change, the Pittsburgh chapter of Physicians for a National Health Program, and most recently here in National Single Payer, involved in that, and the movement and privatization of Medicare. So lots and lots of organization over the years, and it's a real pleasure to be here today. And I want to thank Kay for an incredible and inspiring call to action. You've answered the question why we need a national single payer bill and why we can't do it state by state. You explained why healthcare activists need to commit to a national movement rather than 50 separate movements, and why it's impossible to fight for one and stay committed to the other. I will say out loud what no one wants to say or even whisper. We have taken the bait from the Democratic Party and divided ourselves, diffused our efforts, and sabotaged any promise of achieving single payer. We cannot ignore the inherent contradiction that committing yourself to a state bill precludes fighting for a national bill. There are, after all, only 24 hours to the day. The next question becomes, do we have a national single payer bill worth galvanizing around? So how is the current Medicare-for-all bill deficient, and how can we create a model bill to galvanize a national movement? So a national healthcare program, which is what we're talking about, can only be achieved at the national level. It assumes redistribution of wealth, critiques profit-driven healthcare, promotes healthcare based on need and not on the ability to pay, is anti-inequality, anti-concentration of wealth, and anti-racist. For all these reasons, as we will see, the system must be national and not state-based. We've heard plenty of evidence this weekend to understand that our current profit-driven healthcare system is broken. If nothing else, the COVID-19 pandemic has laid bare the inequities, inefficiencies, ineffectiveness, and frankly, the indifference of our healthcare system. If there was ever a time for reform, this is it. This is our crisis moment when we can galvanize people to dream big, join a grassroots movement that unapologetically and radically demands a national health plan, and really only radical here in the US, sadly, not a plan that we can stumble into along the way after a few innovation states get single payer. We cannot leave healthcare or any human right to the whim of states, just like Medicaid expansion, which leaves millions of poor people out, just like abortion rights, which jeopardizes the lives of women, voting rights, which threatens our democracy, and the rights of transgender children, which can result in children being taken away from their parents. All current and past national proposals and bills for a national health program start with moral coordinates, what I called in my presentation on Friday non-negotiable principles, grounded on the belief that healthcare is a human right and that the system must be universal, comprehensive, sustainable, accessible, and free at the point of care, high quality and evidence-based with equal outcomes, gender-affirming, anti-racist, respects dignity, and is equitable. I'd like to spend a few minutes describing how we arrived at the current Medicare-for-all bill in the House and suggest how it can be improved upon. It started with the National Health Program for the United States, a physician's proposal written by David Himmelstein, Steffi Woolhandler, whom we heard from on Friday, and the writing committee of the Working Group on Program Design at Physicians for a National Health Program, which was first published in 1989 and updated in 2015. The proposal is based on the expansion of Medicare to the entire population, but understands that we need corrections for deficiencies found in our Medicare system. The two most important elements of the proposal are: one, the elimination of investor ownership of healthcare providers so it removes profit-making from the system, and two, banning of private commercial insurance that duplicates public coverage. These two elements alone would be enough to revolutionize our healthcare system. But they go on to require universal coverage and comprehensive benefits, including prescription drugs and long-term care. It authorizes Medicare to negotiate with pharmaceutical companies and subsidizes the medical education of health professionals and personnel, eliminating medical and nursing student debt. The proposal creates global budgets to fund hospitals, taking away the incentive to overprice and overutilize, and proposes a funding mechanism through progressive taxation, folding all public healthcare funds into the National Health Program or the budget. The physician's proposal was the basis for H.R. 676, also known as the Conyers Bill, introduced by John Conyers in 2003 and every year after that while he was in Congress. H.R. 676 turned the physician's proposal that we just heard about into a bill by including all the elements that I just mentioned and adding a few important components, including the following 5 points. 1, a mechanism for the conversion of investor-owned providers. So he answered the question, okay, so you ban for-profit facilities, but you don't want to eliminate the nursing homes and the dialysis centers because we need them, but just, without the profiteering. The bill spelled out all the benefits and portability in the system, meaning you could move to another state and still retain your benefits, including primary care and prevention, approved dietary and nutritional therapies, inpatient care, outpatient care, emergency care, prescription drugs, durable medical equipment, long-term care, palliative care, and mental health services, but left out women's reproductive rights and abortion. 3, it proposed a progressive funding mechanism for the bill. 4, it established an employment transition fund for displaced workers, including salary parity benefits, retraining, and job replacement. 5, finally, recognizing that we had waited long enough and we did not need to do this in baby steps, the bill would become effective 1 year after the law was passed. Now, when Conyers stepped down and Representative Pramila Jayapal took over the bill, she introduced it as 1384 in 2019, and then again as HR 1976, the Medicare-for-all Act of 2021, which many of you, I'm sure, have heard of. The original bill, the original Conyers bill, 30 pages long, was converted into a more detailed 131-page bill. It retained most of 676, except for some critical items, as we will see in a minute, elaborated on much of it, and added important protections, including more comprehensive benefits that include substance use treatment services, laboratory services, oral health, audiology and vision, rehabilitative services and devices, necessary transportation for those needing it, complementary and integrative medicine, and importantly, comprehensive reproductive, maternity, and newborn care. It also gave more funds and emphasis devoted to health equity, medically underserved in rural areas, health disparities, people with disabilities, and long-term care. It created an office, or it creates an office of primary care to expand the number of primary care practitioners, registered nurses, mid-level practitioners, and dentists. It has more robust protections against compensation based on patient utilization, such as value-based payments, incentive payments, bonuses, and other compensation schemes that we're hearing out of the DCEs and the REACH and Medicare Advantage and the accountable care organizations, all those that erode the patient-doctor relationship. And finally, it creates reserve funds to respond to epidemics, pandemics, or natural disasters, including a 365-day stockpile of PPE and contact tracing, which of course makes a lot of sense to us today. Now, while a strong bill, HR 1976 has 4 major deficiencies. 1, it allows for-profit institutions to remain in the National Health Program. To make this clear, today, more than 90% of dialysis centers and 80% of skilled nursing homes are investor-owned. For-profit hospitals cost more, deliver lower or no value care, and have the highest readmission rates for every condition. For-profit dialysis death rates are higher and are responsible for 3,800 excess deaths per year. For-profit home care delivers lower quality care at higher cost. For-profit nursing homes provide less nursing care, have more deaths and greater hospital readmission rates. And finally, private equity nursing home takeovers, which sounds terrible and is terrible, harm patients and raise costs. Knowing all of this, why would we want to give these profiteers our tax dollars? 2, HR 1976 does not have a robust program to take care of displaced workers. It is estimated that about 1.7 million individuals will lose employment because of a national health program. In 1976 sets aside 1% of the budget for 5 years without any concrete salary compensation. Now, amazingly, 1% of $4.1 trillion is still not going to be enough. And so it will not suffice, if only for political and strategic reasons. And because it's the right thing to do, the bill needs to include income parity to guarantee buy-in from individuals who will become unemployed because of the passage of the bill, and a robust transition to pay for it. 3, H.R. 1976 does not include a funding mechanism. As we learned on Friday, the national health expenditures for 2020 was $4.1 trillion. The economic reality of single payer, despite what all its detractors say, is that even after accounting for the increased costs of coverage expansion, remember the 30 million underinsured and the 70 or so million, the 30 million uninsured and the 70 million or so underinsured will need more medical care and deserve more medical care. Under a single payer system, we will spend less money than we do under a current system of no system. Savings will come from paying hospitals and physicians either a global budget or a set fee schedule, savings from lower administrative costs and profits, and negotiated prices for prescription drugs and medical equipment. Now, as Dr. Woolhandler showed us on Friday, existing sources of federal government revenues already currently fund 2/3 of healthcare spending. So we will likely need to come up with approximately 800 to 900 billion annually. Now, with deference to MMT and with or without it, creating a fair, progressive tax mechanism will increase solidarity for the program and protect it from being gutted in the future. H.R. 676 proposes raising personal income taxes to the top 5% earners, a modest progressive excise tax on payroll and self-employment income, and a modest tax on unearned income and stock and bond transactions, and this would make up the difference. And finally, H.R. 1976 would be implemented over 2 years using a complicated and expensive Medicare buy-in option that takes over 10 pages in the bill to explain. This promotes the false assumption that we must move incrementally. It endangers the bill by adding complex administrative steps that will increase costs and not recover savings of single payer, giving ammunition to our opponents. The buy-in disrupts solidarity around the bill because it would create winners and losers. The buy-in option endangers the bill and should be removed. And while 1 year might not be a long time to wait, after all, we've been waiting over 100 years, 35,000 people will die unnecessarily that year due to being uninsured. So these are the changes that are needed to improve H.R. 1976. A model bill would prohibit for-profit institutions and investor-owned facilities and create a mechanism just like 676 for conversion of those facilities into not-for-profit status. A model bill would create a fund to protect displaced workers and include 2 years of salary parity up to $100,000 per year, or we can make that more, and priority and retraining and job placement. A model bill would include a progressive funding mechanism as outlined in 676. And finally, a model bill can be enacted in 1 year. Remember, in 1965, Medicare enrolled 20 million seniors in 11 months using index cards. I think we've got this. Now, this does not turn H.R. 1976 into a model bill, but it does come closer. A model bill would fully protect the rights of immigrants and undocumented people to health, support gender-affirming care, include complete free medical education and canceling of health professional student debt, battle homelessness, properly fund a public health infrastructure, as well as the Veterans Health Administration and the Indian Health Service, and denounce incremental approaches. Once we have a model bill, the next step is to use this bill to build a national movement to achieve national single payer. Now, we can expect resistance from all sides, as Kay mentioned. Every time there has been a movement towards universal health care, that has been an equal and opposite reaction, right? For the passage of Medicare, that's socialized medicine. Clinton's plan, Harry and Louise ads. Obamacare, death panels. Bernie Sanders in the 2020 Democratic primaries, public option or Medicare Advantage for all. And now, national single payer with 60% popular approval, and Democrats in all 3 branches of government. Let the states be single payer laboratories. Now, reading Public Citizen's Roadmap to Single Payer, Steps to Enacting a Unified Universal Healthcare System at the State Level, Reminds me a bit of the Steve Martin joke. How to become a millionaire. First, you get $1 million. So, according to Public Citizen, it's an organization I highly, highly respect. But to get state single payer, first you pass a law. Then you obtain a waiver from the ACA. Then you integrate a state coordinated system with Medicare. Then with Medicaid, and then with CHIP, you figure out a way to deal with workers' comp, address other federal health benefit programs. You avoid getting struck down on Erisa ground, just like Kay mentioned. And when you've done all that, determine how you're going to pay for it. It's honestly easier to pass national single payer. Now, very briefly, Representative Ro Khanna introduced the state-based Universal Health Act of 2021 that would offer pass-through federal fund waivers, including Medicare, Medicaid, TRICARE, the exchanges, and the federal employee health benefit dollars, to states that have plans to provide comprehensive health benefits to 95% of its residents, and the residents were defined as citizens or lawfully residing immigrants, so not undocumented, within 5 years. Now, the words single payer are nowhere in the text of the bill. I checked several times. There is nothing in the act that precludes giving Medicare money to private insurance companies, strengthening profit-driven companies to pursue obscene profits, deny care elsewhere, and buy more politicians to oppose national single payer. Now, the bill has 25 co-sponsors, all co-sponsors of HR 1976. I suppose they're hedging their bets, if not federal, then state. But the fact that it doesn't have more co-sponsors is a good sign. Maybe Congress is waking up to the realization that we can't really do it at a state level. Well, that's my polite explanation. The health of a nation's people is a foundation of their well-being. As we have seen during the pandemic, our country has failed to provide measures that would address everyone's well-being equally or equitably. Unnecessary and excessive profits and administration inflate the cost of healthcare, drain public resources, and enrich corporations at the expense of the nation's health. Healthcare is a human right and a national responsibility. It cannot be left up to the states. As Steffi, who was on our panel on Friday, and David Himmelstein wrote in 2008, at the beginning of another global catastrophe, it would be shameful to squander the present opportunity on yet another round of reforms that are politically realistic but economically chimerical. Let's write a bold, beautiful model national bill. Then let all activists in every state use it to achieve national single payer, national improved and expanded Medicare for all. Thank you.
Joy?
Sorry, I had to try and find the mute button.
But you found it. Good for you.
You have a blind chick hosting all these panels, okay?
You're doing great.
Thank you so much. Again, yes. I do want to talk to you as an immigrant. One of the things that I, find especially frustrating about this state by state is because, like, let's take Washington State, for instance, 4% Black, median income $77,000. So when you're doing it state by state, there absolutely is a connection to sexism, ableism, classism, and racism. So I kind of wanted your take on that because you touched on it slightly, but I just want to kind of delve in a little further from your perspective.
So if I'm understanding your question, so if Washington gets the bill, then it doesn't necessarily mean that that it's a pretty homogeneous state. Is that what you're asking?
Exactly.
Right. Well, that's true. I mean, absolutely. It does mean that only the population of Washington would have the right to health care. You cannot call that Medicare for all. Honestly, you can't. It will be health care for all of homogeneous Washington state. Yeah.
Absolutely. All means all, people. All means
everybody
all.
In, nobody out. Mm-hmm.
Exactly. So thank you so much for that. We are going to pass it to Steve now. Steve, take it away.
Yeah, thanks, Joy. And Anna and Kay, you guys both really, really humbled me with your knowledge. Really, really appreciated your understanding of the healthcare system. My expertise is less in the healthcare system itself and more in understanding the economic framework and the neoliberal structures and power dynamics that take place behind the scenes. So I'm going to go ahead and focus my presentation talking about exactly that. And first of all, let me introduce myself for those of you who do not know me. My name's Steve Grumbine. I am the founder and CEO of both Real Progressives and Real Progress in Action, a 501c3 and C4 respectively, as Jamarl Thomas will often say. I am also, and I have an MBA, Master of Business Administration. I have a Master of Science in Technology Management. I have a Bachelor's in Information Systems Management and a bunch of certifications and so forth, which put me great in the IT space. So technically speaking, I don't have any expertise in this category at all, other than the fact that this is what I devote 100 hours a week of my life to, is learning about this movement and trying to understand how to make these things come to be through the lens of modern monetary theory. And so what I want to do right now is just take a step back for a second and talk to you all about something that was raised by the previous, in particular, Kay, about the race to the bottom. So the states, all of our states, are what we call currency users. Every one of the states receive money from the federal government. They don't create money of their own. So all of them are dependent on the federal government to do its job. And so what happens is that the federal government and our entire worldview is that of what we call neoliberalism. And no, that is not shorthand for corporate Democrat. That is an entire ideological position that goes across Republicans, Democrats, and it's around the world right now. You see it with the IMF, you see it with the WTO, you see it with the World Bank, you see it around the world. Whenever the global South is taken into consideration, we see the global South raped and pillaged for its real resources. And so a lot of what's going on in the Medicare-for-all discussions has to go with that understanding that we are living in a world of mass privatization, a world where the politicians, the corporate interests are all focused on the idea that the market, the free hand, the free will of the market, the invisible hand of the market, going back to Adam Smith, this whole concept is about markets and the ability for corporations to maximize profit and maximize shareholder value. And so when you look at our states, many of the states, when you look at their fiscal position, they are hurting. The vast majority of states in this country do not have their pension plans fully funded. States like Kansas, for example, were so bad, they had deprived the public purse so much of tax revenue that they were using school books that were falling apart. They couldn't open schools. Kids were not able to have any of the basic services they need. And so what states like Texas do, Texas puts a big old sign up and says, hey, we're ready for business. All you corporations, come on down here to Texas. We'll take the tax away from you. We'll take good care of you. And so there is this race to the bottom where the states are literally competing with each other. So what happens when you have a state that is, I don't know, they have a major employer pick up and move and leave, say, Detroit, Michigan, and go down to Dallas, Texas. You leave a hole behind, a donut hole behind, where people are literally left without any kind of funding. And so the state revenues, the local revenues dry up. The schools dry up. The roadways can't be fixed. All of the aspects of the local economy are in jeopardy. Okay, this is why when you look at when there's a national disaster, we have a FEMA or a federal emergency, right? Federal, right? Because the federal government is the creator of the US dollar. And people don't realize this because you've been propagandized to believe that it's the Rothschilds or it's some weird nefarious thing with private banks funding the federal government, which isn't how it is at all. And the panel after us will talk about funding, how this stuff gets funded. But I want to talk specifically about the dynamics that make this funding really super important. If you have a healthcare scare, like, I don't know, a pandemic, and you have that go throughout all the states, first of all, let's just say hypothetically you were able to get states like New York and California to be able to provide this. They have unique economies that are very, very large, larger than some of the countries around the world. And so based on their ability to bring money into the state, they may be able to survive some of these ebbs and flows. But the vast majority of the states are underwater. The vast majority of them have huge deficits, and they start horse trading. They start trying to find new ways to fund things. In the state of Pennsylvania alone, there was a $600 million shortfall, budget shortfall a few years back before the pandemic. Their answer to supplying that shortfall was to cut services, number one, and number two was to begin to allow fracking companies in the middle of a climate crisis to begin fracking throughout the state of Pennsylvania. Because it is a purple state, you have a lot of differing opinions about how that tax revenue should be spent, because at the state level, it's all about taxes. States are heavily dependent on tax structures. And so what ends up happening? Those local states fight with each other. The counties fight with each other, etc., for revenues. People, though, have a different perspective. What do the people with money do? They want to live in a low tax area. So you have what they call flight. And when people move out of those areas, you're left with a tax hole, a hole in revenue. It's really, really dangerous and damaging to all the other social fabric of that community, not just Medicare, but everything from pensions to roadways. Think about our bridges and infrastructure in this country. Many of them are D-rated and below. So as you begin to think about why the race to the bottom is so important, begin to realize all the things that the state is responsible for. Unfunded mandates from the federal government are huge. There is massive, massive, massive unfunded mandates that are pushed down to the states. So what do they have to do? They either have to raise taxes, or they end up not in compliance. And then the federal government has, penalties, and they don't provide the services that they were going to provide. There's different acts like Act 89 and stuff like that in Pennsylvania. Use Pennsylvania as a perfect example, where monies from the federal government are provided for roadway infrastructure, but they are encumbered, meaning they are specific. They have to be targeted to do a specific thing. Well, that doesn't mean they can use that as a general fund. So all the other services of the state end up drying up. They've got to find things. So what happens? Look at places like Ferguson, where they use fines, fees, and penalties on the poorest Americans to fund their police, to fund their social services, to fund their schools. They have cops at every corner waiting to get people with speeding tickets, trying to fund their local and state initiatives. This kind of behavior, this kind of model is the absolute opposite of what we want our country to be like. This is not how we want things to go. And so you bake in inequality right off the bat, because every single state ends up being in that position. Now, there are a few states out there, obviously, that have taken on the role of being the let's just slash and burn all the taxes and bring business down there. They have the employment. The people that are doing really well do really well, and the people that are doing really bad do really, really bad. Now, why does that matter? There's 26 states in the United States that have ballot initiatives right now, 26. So of the 50 states, 26 of them could even put a state-by-state approach up on their, to vote for, right? But you start getting into situations of how do we have what we call a scalability, or the ability to provide care at scale, to be able to make sure everyone has care. And they can't do it. It's fundamentally impossible for them to do it, because one of the most important things is not just the money. It's how do you resource this initiative? How do you make sure you have enough doctors, right, for the increased load? How do you make sure you have enough nurses, gurneys, x-ray techs, phlebotomists? How do you make sure you have enough clinics and care facilities around to support this new influx, right? And so now you've got to account for not just the payments of the premiums, but you've got to account for creating the actual real resources to provide the care. Now, a state that doesn't have the planning mechanism to bring in the care for all that is also setting everyone else up to fail, because they're pinning their hopes on one state getting it and it becoming this watershed event where everybody suddenly becomes enamored with it and suddenly everybody has Medicare for all. It doesn't work that way, and it will never work that way. Okay. Only the federal government has the ability to do this. But one of the most important things, and this is one of the dangers I heard, and I've just pushed general pushback of the last speaker, Anna, is that when you think about Social Security, FDR made a deal with the devil to tell everyone that Social Security was funded by your FICA dollars, right? That you're investing in your FICA. Well, this is a lie. It didn't happen. That's not the way it happened, but he had to do it for political reasons. But here we are now in the year 2022 with still previously people like Paul Ryan coming out there in Congress talking to Alan Greenspan. Wouldn't it make Social Security more viable if we had private accounts and we were privatize it through like 401k plans, stuff like that? And thank God for a moment of actual honesty from King neoliberal Alan Greenspan himself, where he said, no, it wouldn't make it more. The key here is, can we create an economy where the real resources are for sale for purchase? Okay, so what FDR did by making this FICA thing happen, created the most regressive tax possible to fund a service that should be just a benefit of living in this country, an investment in our elderly, and provide the COLAs that are required. Because the one thing the federal government absolutely can never run out of is U.S. dollars, because it creates U.S. dollars out of thin air. Okay, now, I'm going to take you on another journey here real quick, and this one is an important one that many people may not understand. The CBO, we always talk about the CBO scoring and things like that. One of these key metrics is GDP. And when you think about GDP, it's gross domestic product. It's basically the balance sheet, all the money that the country made. Doesn't matter how it made it, just whatever economic activity creates that GDP. And so this indiscriminate number called GDP is held up as God. But what happens when you make Medicare for all for all? Once you make Medicare for all, you eliminate all those insurance companies. You eliminate all the extra nonsense that has been put in place to deny care as opposed to provide care. And so all that economic activity, all that meshuggah right there is washed away. And that nonsense right there is part of GDP. And once that GDP is eliminated, you end up with recessionary conditions. Now, all of a sudden, you end up with a situation where instead of raising taxes, you need to cut taxes. Counterintuitive, I know, for all the folks out there, and there are many who believe that taxes erroneously fund spending. But taxes literally are deleted. So if you're taking money in for taxes to pay for things, well, number one, you're lying to America. You're lying to every citizen in the country. That's a lie. We don't want to do that. We don't want to start off baking a policy to provide health care founded on a lie, because there's nothing worse than a lie, because it comes back to bite you like FDR's lie did with Social Security. So we want to eliminate these concepts of trust funds. We want to eliminate these concepts of pay-fors, because the fact is that if the government isn't covering all of it, then it's left to somebody else to believe they're covering it, which means that it's not really a right. Now it's dependent on a tax dollar. And that should never be the way it is, because affordability is the one thing we've got to eradicate from our mind. We got to stop thinking of how we're going to pay for it. That needs to be eliminated from all conversations, because we need to understand how the currency is spent into the economy. Okay? So when you think about the state-by-state approach, you already know that with more than half of the states really struggling to fund even their pension programs, how in the world could they take on the burden? And it would be a huge, unnecessary burden at the state level. They would have to slash and burn. They would have to raise taxes. They would create situations where the big taxers, the people that are actually funding their local governments, would say, no mas. They'd pick up and leave. This is called white flight. We see it all over the place. This has happened and left communities of color destitute, as the inequality baked into that model is so severe, so harsh, so absolutely exacting, that if you don't understand this, you might be inclined to advance a model that would create that very condition. And I'm here as my role in this thing to make sure that that doesn't happen, to make sure that you understand that taxation literally is deleted. So in the bathtub of our economy, okay, we have a spigot coming in, that's federal money spending into the economy. And over here we have another spigot, and that is private debt pouring into the tub. Right now, private debt is rising through the roof. We can see it in our federal student loans. We can see it in all these things, all this nonsense. It's a burden to regular people. But down at the bottom of the drain is where the taxes come out. Private saving, we call that leakages. And so those leakages are not funding anything. Do you understand? They're not funding anything. The only tax dollars that fund something are your local and your state taxes. Federal taxes are literally deleted. Social Security FICA dollars are literally deleted. The FICA score, that little sheet you get in the mail that says how much you paid all of your life, that's a numeraire. It's merely an accounting identity to say, yeah, you paid. But those dollars are deleted. There's no fat stacks rolled up at the Federal Reserve with Granny's old wooden nickels or Buffalo, none of that stuff. There's no hay pennies in there from yesteryear when they were saving up. It's all gone. It's all new money every time the government spends. But states can't do that. States have to raise taxes to pay for things. And what happens when people start moving to different states and all of a sudden they leave the poor really, really destitute? This is a problem that has implications way beyond Medicare-for-all. This is a problem with a Green New Deal. This is a problem with college for all the different things that we crave as progressives. And so when you see media on television sitting there lying about taxpayer money, or when you see alt media pretend like these aren't issues that should be talked about in every single live stream, not just some, not just when the MMT is on, but every single one, that they're abdicating their role in this movement by not talking about it every single time. Okay? When they don't do that, they are setting the stage for more misery. And they got blood on their hands. So this is where we've got to get smarter. We've got to really begin to recognize that the parameters of Article 1, Section 8 of the United States Constitution, while it was built for capital, it was built to protect capital, this one area, Article 1, Section 8, gives the power of the purse explicitly to Congress. Now, we can go one step further. We know that lobbyists have control of our government right now. We know that our government is largely captured by special interests. So this is where the state-by-state crowd gets their oxygen, because there's valid case there to be made. This is why it is important that we understand the economics, we understand what's at stake, and we organize at a national level to take this thing down. And we have to be ready to sacrifice. We cannot just be, well, it's a little inconvenient, don't really feel like doing that, it's a little, I don't know. We've got to really understand that we are in a war, and it's a global war, because while we're fighting to get single-payer healthcare in the United States, our U.S. government is busy exporting neoliberalism to the UK, who already has a national health service that they're now trying to privatize. In Australia, they have a healthcare service as well that the United States is there to say, we're here from the US and we're here to help you privatize your stuff. And the World Bank and the IMF are doing it around the globe. So while we're trying to fight this battle here, they're fighting it the other way to dismantle what they have outside. So you must understand this war is not just a single issue war. It's a bigger war. And so this is where the MMT angle comes in. And if you see an MMT post, you start hearing people talking about this, make sure your ears perk up. This is for you. You need to know this, because as a warrior to make this stuff happen, if you're not prepared with the tools of the trade, if you don't understand what's at stake, you're likely to make a really bad mistake And you'll watch as the California folks ignored the MMT message. You watch as the Washington State folks ignored this message. You watch as the New York folks ignored this message. They clung in groups that self-fulfilled. Yes, state by state is the right answer. And then they found other people that were opportunists to make them feel like it was the right answer. But the truth is, there is no wiggle room. There is absolutely no wiggle room. The race to the bottom isn't just happening in the US, it's a global thing. And we must be aware of this battle. We must embrace this paradigm so that we can fight back. And that, my friends, is why I'm telling you right here, right now, the only way forward is a national-based approach. But you must understand the powers that be are fighting you for far more than just Medicare for all. They're fighting you for the very belief system that there should be no public property. There should only be private property. And this is the battle. This is your class-based struggle. This is the entire shooting match right here, my friends. And so I hope that you'll take the time to learn this stuff, because these wonderful women that were on the panel with me have brilliant ideas of how this needs to be done. That ain't my specialty. But I'm here to tell you that this global scourge of neoliberalism is going to make it a challenge that you didn't even anticipate until you see the broader inputs, outputs, tools, and techniques of that entire mindset. Once you embrace that and you stop skipping it so you can be friends with everybody, once you take a tough edge and you realize how important this battle is, you probably lose a few friends in the process. I'm not going to lie. But it's worth it, because we're going to gain a lot more, because this is the battle. This is the battle. You've got to embrace it to move forward. So, Joy, that's what I got here. You're muted. You're muted. You're muted, Joy.
Okay, no lie, every panel I've done the past 3 days. I've only done a show for 5 years. I don't know how it works. So I want to actually talk about one of the, I'm not going to be generous. One of the lies state by state people push is cannabis. And Steve, I'll go to you first. Just for people watching, I want you to really, really think about this, because we hear, I want it to work like cannabis. Cannabis worked on a state-by-state level. Well, it was introduced in 1994. There's still less than 20 states who have passed it. That's the first thing. Second thing is, medical cannabis is not even legal in all 50 states. Okay. Another thing is, cannabis actually brings revenue. Medicare per state would cost revenue. That is a very, very different thing. So Steve, touch on that a little. When you hear people say, well, it's state by state is going to be just like cannabis monetarily, touch on the difference of the bringing revenue and costing revenue.
Well, first things first, it's not a spending bill. You're just allowing a business to come to be. And so there's no funding issue there, right? The only issue is where the legality is. Was it a federal law or state law preventing it? And there's federal legislation, sadly, that has this stuff marked as a schedule, whatever drug. And so that's really what you're dealing with there. But that could even be solved with a pen stroke by a forward-thinking president, an executive order. It wouldn't be forever, because an executive order only lasts as long as the president is in office. But it's totally not the same thing, because, like I said before, our Constitution, which I despise, but our Constitution nonetheless is the law of the land. And it says Article 1, Section 8 gives the power of the purse to Congress. And so funding for Medicare for all and things like that is really what the issue is here. The whole concept of state by state. Well, yeah, every state's going to have their own little pitch battle as to whether or not they want to let gay people marry each other, whether they want to let, trans kids exist or be harassed, whether, all these different aspects of inequality are baked in. And that is decidedly a Dixiecrat, freaking scumbag, Civil War level, 10th Amendment kind of nonsense that is really been the bane of our existence for an awful long time. It's largely why the 14th Amendment had to be invoked, as far as the equal, the clause, the equal, whatever clause. I'm butchering that, but you get my point. I think it's really important to understand that the state by state approach is decidedly playing off of states' rights. And it's playing off of a role that has been used as a cudgel against the poor, against Black and brown people, against gay people, against every other aspect of society. And you see the fact, to your point, that marijuana is still not legal in all 50 states. And there's federal legislation that still hasn't even played a part in it. The only thing they're doing is making a decision to not prosecute. They could still go after everyone, even though all this stuff is going on. The executive branch is choosing not to execute the law as written. If they did, these people could all go to jail right now. It's very precarious as it stands. So very, very different. Just drastically different, like comparing apples and oranges.
Absolutely. And then to expand on that,
Commerce Clause, sorry.
Oh, no, people need to hear this. And then to expand on that to the ladies, something I've noticed, and many activists have noticed, that we run the risk that when states legalize cannabis, they don't really fight for it other places anymore. It becomes, even unconsciously, it becomes a very I got mine. And that would be a huge risk by state as well. When you have your state in the title of your organization and things like that, are you going to continue to fight for national if you already have it, or even on close to the same level? We have not seen that with things like cannabis. So to the ladies, we can go. Kay, if you want to go first, you want to touch on that?
Well, it's hard for me to imagine that a state can do it, because I think that the barriers are there. So if we can never get it passed in the first state, and we see states as essential to a chain of getting to a national, it means that we never get there. But I mean, it's true. Once you get it in one state, it's not going to mean automatically it happens everywhere else. And we see that with voting rights. I mean, that's a huge problem. And winning at one place doesn't fix it. And people don't say, oh, that looks great, let's do it nationally. That's something that has to be done nationally. And the same thing with abortion rights. You can't fix it state by state. We have to fix it nationally. And, if states could actually do it, I don't know if it would help or not, but they can't because of the barriers. There is no law that says you can get a waiver to put the Medicare money into the state. So you can't really do a bona fide single payer. You can't get the full savings. And, single payer is based upon we save by removing the profit makers in the insurance industry, and then we use that, to expand the care to everyone. So it just doesn't work. It may work with other things, but it's certainly not going to work with healthcare.
And that's a good point as well. If it would pass by a state, which gives those elected reps sole control over that, establishment Dems, Republicans, everyone will be looking at those flaws and for reasons why we shouldn't do it anywhere else. And that would just be a given. Look, there's problems here. This happened with that, and now we shouldn't implement it anywhere else. So that's another, risk that would come with that. Dr. Malinow.
So, as important as cannabis is for a lot of people's health, it's not the same thing as health care. So some state people might say, well, people aren't fighting for cannabis at the national level because it's not all that important to everybody. But, healthcare is certainly going to be important to everybody. So we will be able to galvanize, once we get one state, other states will follow suit. To me, the best example of not using healthcare at a statewide level is the expansion of Medicaid. And which under the Affordable Care Act, it was supposed to, so the expansion of Medicaid was supposed to be for every single state. And what happened is that I think like 24 states sued the federal government, and it went all the way up to the Supreme Court. And then the Supreme Court ruled practically all aspects of the ACA constitutional, but it ruled that the expansion of Medicaid was constitutionally coercive. So we have precedent that if one state decides for healthcare, that I am sure that other states will take it to the Supreme Court, and it will probably be ruled, against, for the state against a national program. And as a result, there are 12 states today that have not expanded Medicaid, and I do not expect them to expand Medicaid at all.
Absolutely. Great point. And another panelist said, I believe it was Friday, that some of the Medicaid expansions will be up very, very soon because of the pandemic. Some were extended, and then many will be dropped.
So that's a little different. So that was me, but that was a different point. That's a different point. All the expansion from the pandemic has been in states that expanded Medicaid. And so even in the states that expanded Medicaid, they expanded further, but those are going to be restricted, and up to 15 million people in those expansion states will lose Medicaid, including 6 million children. Yeah.
Incredible. Kay, you touched on something that I definitely wanted to talk about, and I'll open it to the panel then. But we hear about Canada a lot. Well, they passed it there. But a few things I wanted to mention is, and I got some of this information from Karen on our second panel Friday night. So it still took about 4 years for Canada to pass it. Since it passed province by province, very much like state by state, because of that, some don't have dental, some don't have sight, eye care, things like that. There are also certain provinces that are trying to repeal it, and they very well could, which means I might have it, you might not, your neighbor might have it, you might not. And so it's not an all situation. It is the same way it would be state by state. It is a single entity that could be changed by itself. And then, the arbitrary borders, are going to make a difference. So there's that aspect. But also, Karen was saying that some provinces, even because a lot of the doctor appointments are virtual right now because of the pandemic, if you have an appointment after 6 p.m., you pay out of pocket. Nothing, no insurance, no nothing, except it. Out of pocket. So, they're allowed to put these certain contingencies when it is province by province, as it would be state by state. So, Kay, I just wanted to start with you and kind of get your takes on the danger of being able to put quantifiers on, people's healthcare.
Yeah, I think that, Canada's so much better than we are that we tend to think that it's pretty good because, in fact, people basically get their health care. But, have friends in the union movement in Canada, and they are terribly critical of their system. They are screaming that it's underfunded, we have to put more money into it. We're not getting adequate physical therapy, et cetera, et cetera. So, I think the battle continues even after you win it. They haven't been able to take it away because there's massive Canadian support. You ask any Canadian, do you want the US system or do you want Canada's? And they're going to say, we prefer ours. And then if you ask them, well, are there changes you would make? They have lots and lots to say about that. But varying from province to province is not a good thing, having benefits in some areas. I think the dental varies. I've heard the union folks talk about, I think maybe the kids are covered, but not, they negotiated for working age people in some of the provinces, and it's a variation, and it's not a good thing. I know Karen Palmer wishes that they had a national system so that they didn't have to win things one province at a time, and they could actually get some control over the planning and make it more effective. But it's still so much better than ours that we can use it as an example of something better, where at least people don't die because they are unable to walk into a physician's offices because of their copay or their deductible.
Absolutely. Dr. Malinow.
So I think the example that Karen Palmer was talking about is that it's Canada's telehealth since the pandemic has opened up. And so, for example, the benefits in Canada are portable. So if you as a person go from Saskatchewan to British Columbia, you can still go to British Columbia and get healthcare there. But the interesting thing about telehealth is that you are in Saskatchewan and it's 6, or let's say British Columbia, and it's 6 p.m. or whatever. Well, I can't get the time zones right. Okay. But basically your doctor closes. No, you're in Saskatchewan, your doctor closes, and then you want to get telehealth from somebody in British Columbia because it's only 6 p.m. there. And yes, you can get, because their doctor's office is still open, but then because the doctor is not in your province, you would get billed for it. And I think I'm understanding that correctly. If you had a national program, then you could get, healthcare from any doctor in where you are, right, through telehealth without getting billed for it. So and there's just no guarantee that if you have a state-by-state system, as Steve was talking about this, it's the capacity is going to be commensurate to the amount of money that you put into it, right? And so yes, California will probably have a good system, as will New York and maybe even Washington, because they have a pretty homogeneous population. But if Texas should even get there, it's not going to be the same, nor will Alabama, nor will Louisiana, nor Mississippi, nor, even West Virginia, with all their wonderful, great intentions because they expanded Medicaid. If they're a poor state, it's just not, it's going to be very, very, very unequal healthcare.
Absolutely.
I want to test drive. I want to test drive it's okay. I want to test drive a thought with this concept that we're talking about here. So, when you see downturns in the economy, we have things called automatic stabilizers that kick in without anybody passing a bill or having any hand wringing. They just happen, right? So we have a drought, we have automatic stabilizers that kick in for farm subsidies. We have unemployment. We have automatic subsidies for unemployment. We have all these different factors that kick in to insert money back into the economy to prevent a recession. We have buffer stocks. We have all these things. We don't have funding for them. We don't set aside $50 million for these things. What happens is they just spend whatever needs to be spent when those automatic stabilizers kick in, period. Okay. So if you think about the concept of healthcare as a right, get all the Medicare-for-all out of your mouth for just a second, set it over to the side, and just think about Medicare or healthcare as a right, as an automatic stabilizer. when things are needed, the money is there, period. There is no, oh, it's not affordable, we pay less for this, or who cares? At the end of the day, the government is the controller of all that money, okay? And this is a really, really super important thing, because you have no idea when the next pandemic is going to hit. And you have no idea if some spill is going to happen that's going to create a lot of cancer or any number of things. We have no idea what climate change will bring in terms of healthcare crisis as well. We just don't know. And so why would we budget that? It's like the most ludicrous thing I've ever heard in my entire life. And this makes the state by state even more redonk, because they have to be budgeted, because they have a law that says they must have a balanced budget. So they're going to be leveraging themselves like a lot of these states that have been gutted by vulture capital, where they go out and buy all these bonds, they invest in private, real, just anything to make money, because they're so strapped. And so if we don't have an understanding of an automatic stabilizer approach to healthcare, where the money just is inserted, where it doesn't matter, I don't need to know, it needed, spend it, right? Now, the real regulation has to be on price controls and patents and stuff like that outside of the care. The care should be irrelevant. We shouldn't even have to worry about that. Let the federal government, who has the impossible task of managing and regulating all these different interests, let them deal with that. Let us have health care and not worry about the cost. We shouldn't have to pay a nickel for care. We shouldn't even have to pay a penny. Okay. And if you think about it as an automatic stabilizer and get rid of that budget mindedness and cost savings here and cost savings there, if you think about it that way, and that's really what it would be if it were a federal program, because they're not going to cap off healthcare expenditures. Oh, well, shoot, guys, we hit our healthcare budget in March. We can't spend anything for the next 9 months. We're over budget. They're not going to do that. That's not how it'll work. The program itself would have to be basically serving as an automatic stabilizer. And there's no state, not California, not New York, not Washington, that could handle it as an automatic stabilizer. So if you put it in those terms, changes everything. And this is my first time saying this, but it makes so much sense now that I understand the mechanism. Why in the world would we not want to have it that way? Why in the world would we want to get wrapped up around the axle of how to pay for it? Just insanity to me.
And Steve, as a fellow Pennsylvanian, how bananas is it that you and I, could have a doctor over the hill in New Jersey and have to pay out of pocket because we can't, it's out of our state? That's bananas. Like, people really need to think about this. If you get state by state and you move, goodbye, buy healthcare. Or you are on a border and your doctors are in the next town over, pay out of pocket. Like, this is how unequal it is. I want to kind of touch on the vote harder, well, we can do it with politicians because that's working so great. Pelosi supports state by state. That's enough for me to be like, no. But let's look at California. Okay, so we have the gentleman who is literally the head of CalCare vote against it. So, first of all, I recommend everyone read the CalCare bill. It is not Medicare-for-all. People label it that, and it is not. There are plenty of caveats for that money to come in there. And how much easier is it to buy one politician, as we just saw, than buy Congress and Senate who have signed on? There's a lot more than one person who has signed on to Medicare-for-all. So one way you're buying one politician, and in another way you'd have to buy all of Congress, all of Senate. So even though money in politics is, Beelzebub itself, still, which one is easier to get by? And we saw that in California. Kay, what were your thoughts on California's bill and the fact that people are calling it Medicare for all, and also the fact that it blatantly failed.
Well, I'm struggling to, as a Kentuckian, to understand California. It's extremely difficult for me to understand. I know that in 2006 and in 2008, they passed some form of thing that people called single payer, and then it was vetoed by muscles. Schwarzenegger said no. And, it seemed to me that maybe they passed it because they knew it was going to get vetoed. But even back then, there was no funding in it. So they passed a bill where the key thing is that you have to replace this employer funded system in a state with some form of tax system, and they didn't put any money into it. So I still don't understand it. And I've seen then, I saw that this guy named Rendon,
Yeah.
he did it earlier,
Yeah.
and then he withdrew the bill. And then when this other guy, what's his name, Kalra, is that it?
Ash Kalra.
Yes.
Kalra did it. When he withdrew it, then Rendon condemned him for having withdrawn the bill. And, I'm befuddled. I don't know what the movement there believes that it can do, because it seems to me that they've been working at this for a very long time and they don't have anything in place that is hopeful that they can accomplish it in one state. So, and you see people, there was just an article in The Nation that we're going to go after it again. I don't know. It's I'm puzzled by it, but I don't think that they're going to be able to fund it on a state basis or to accomplish that. So I wish we could get that whole California movement helping us to go after Nancy Pelosi and all of the, what does California have? They have, what, 50 or so in Congress?
So close. So I'm actually in California, so I can tell you it's very interesting living here and living through AB 1400. In fact, there were two bills. One was sort of like a companion bill to the single payer bill, and the second bill was the funding bill, which didn't go anywhere because the initial bill didn't go anywhere. But the second bill, the funding bill, was for a constitutional amendment, because in order for California to raise the taxes necessary, you need to have a constitutional amendment, right? So that was going to be their funding mechanism, because that was the argument last time, that they didn't have a funding mechanism, and now they do, which is basically, okay, well, we'll just put it up for a vote. But I think the real problem, well, first of all, as Kay, you just mentioned, yes, there was an article in The Nation that said, basically rinse and repeat, right? We're going to just keep doing this. We're just going to keep doing this. And that gets, I think, to the heart of the problem, because, and I have to say, many of my health activist friends are state single payer people, because in California, that's pretty much what you are. And, I hope that they still consider me their friends after today, but it takes all activists away from the real effort. It just completely sucks out the energy in the state for anything national. And so you're absolutely right, Kay. Yes, I wish we could get all of these activists to push on Nancy Pelosi to bring this HR 1976, as imperfect as we're seeing, to a floor vote, or to push Dick Neal to have a hearing on it. But it's just not happening, because the people in California are all consumed by AB 1400, and they lost. And a lot of them put in a ton of work, and I'm so sorry to see that for them, really, because my heart goes out for anybody that works so hard. But they're going to do it again.
And you know, that's a great point too. You cannot trust that, you know, reps from single states are going to support. Like we see when Bernard introduced it in 2017, who signed on? Kamala Harris, Kirsten Gillibrand, people who then ran for president.
Corey,
outright said Elizabeth Warren. No. What they ran 2 years later, and all of a sudden, no, I don't support that because we only had 15 signatures then, and they knew it wasn't going to pass. So look at me, I'm so progressive. I'm signing this bill, and then what happened? 2 years later, they run for president. They show their true colors. That could absolutely happen on a state-by-state basis. We have no reassurance people like Elizabeth Warren are going to sign on to the Massachusetts bill that is being, you know, talked about being formed. Steve, what would you like to add?
Well, what I'd like to add is a just an observation, right? Just an observation. When you see California and you see the gatekeepers and the progressive movement there, the headline activists that kind of keep in their own little echo chamber in their own little bubble, and it's just this kind of like popularity contest, like in high school almost. And they literally only focus on their things. And if you say anything that distracts from that echo chamber, you're excommunicated, you're canceled, you're done. And I'm feeling for Anna, because I mean, that's the culture. And it's not just the culture there, though. It's this state-by-state approach. I mean, it's everything from public banking and not understanding the role of the federal government of the currency issuer. They don't hear anything but what they hear in their own echo bubble. And so it's penetrating that, somehow or another, getting past that walled garden, that membrane that blocks out any contradictory information. And somehow or another, getting someone on the inside to say, hey, guys, eyes up here. Let's deprogram the cult of California or deprogram the cult of New York and start getting you to think at a collectivist national level. And unfortunately, this state-by-state approach, this 10th Amendment approach, is being passed off as progressive, and it is not progressive. Let's be clear. It is not progressive. Progressive, if you think about a union motto, what is one of the most key union mottos? An injury to one is an injury to all. That is a progressive class-based issue right there, right? When you say, hey, an injury to one California is an injury to all Californians, but not the rest of the country, I got a real problem with that. And unfortunately, penetrating that very, very tough membrane that is the echo chamber is a real challenge. And you saw that in the first March for Medicare. As you looked at the California talkers, they weren't talking about national health care at all. Everything they talked about was their state approach, which really hurt the movement, quite frankly. I really haven't quite forgiven them for that. And it's the same with whole Washington. We actually sat down, just to be clear. I had Fadl Kaboub, let me say it clearly, Dr. Fadl Kaboub. I've had people like Dr. Bill Black, who is a law professional as well as an economist. I've had Poti, who is an economist, a PhD doctor who understands this as well, from Virginia. We had them all talking to these individuals in whole Washington, trying to explain this stuff. And it was like, you can't know that. You can't know that. No, I can know that. That's the thing. That's the beauty of understanding economics. I can know that. I literally can know that. It's not debatable. I'm not wondering. It's not a question in my head. I know it. And it's not just me that knows it. It's the people that actually done the homework. This is why I would never push back on anything about policy and prescribing how to deliver health care, because I'm not an expert in that category. I'm not really an expert in anything. I'm just well informed, and I'm carrying the message forward as an activist for the funding aspects of this. And the people that know, and they have said point blank that while it's noble, and we certainly understand the frustration of trying to deal with a national thing, with all the problems that are facing us, in terms of actually getting past the lobbyists and getting past the money in politics and really understanding the Constitution wasn't written for democracy. It was written to protect moneyed interest. It was written to protect capital. Hey, have as many slaves as you want, have as much land as you want, create as much carbon as you want, do whatever you want. As long as you're the capital owner, you're good to go, man. We're here to protect you. But us, we the people that are begging, like Tiny Tim, please, sir, give me some porridge. We have no standing with that government. So I think it's a fair thing to say that wherever we go, we are facing this dynamic. So it's very important to organize strategically and with massive numbers and be disruptive. Don't be kind and gentle and sweet and death is not sweet. Dying of cancer, bankrupt is not sweet. There's nothing kind about it. There's nothing gentlemanly about that. Neoliberalism and austerity are murder. And so until we stop playing patty cake and worrying about bombs in Ukraine and start realizing that there's more bombs to go off here by the power of economic malfeasance and ignorance, worse, the ignorance, the economic illiteracy that is pervasive in our movement and pervasive in alt media and pervasive in our regular media. And I'm not even sure that it's ignorance on the regular media. I think that they genuinely are carrying the water for this lie, okay? But I think alt media is just straight up ignorant about it. And they're like California. They're in their echo bubble. They don't want to hear anything other than what their echo bubble is. And so they stay insular and they say things that each other say. They repeat what each other says. And this is a real challenge for any movement to be built, for any kind of movement for this kind of bill at a state or national level. We've got to penetrate the alt media bubble and get people to stop pretending like this is some secondary issue that's boring. It's the most important issue. It's the issue because we get nowhere without it. So that's my take.
And you're so right. I mean, yes, Twitter can be like the devil, but at the same time, it has good things. It's good for organizing. It's good for support. But yes, when you say, why do you support only state by state? We support national. When's the last time you posted about it? I see nothing on your pages about national. Well, that's ideal, but we're focusing on no, national. Stop saying all and then hashtag state by state or, things like that. It's hypocritical. And as a disabled person, I'm not a fan of you saying I'm only fighting for disabled people within these arbitrary borders. Sorry, Joy. Sorry about you and the millions of other people who are disabled. I can't. That's too much work. I'm just going to focus on my state.
So let me bring up one thing. There is a person, Catherine Lewandowski, who has been posting throughout this thing, and I'd like to bring this up. She says, Andy, if you can bring up, there are plenty of economists, Steve, that do not agree with you. Can you bring that comment up for just a minute, if you don't mind? Because what the concern here is this: neoclassical economists throughout history have disagreed with any kind of heterodox thinking. But the fact is that MMT is the only coherent, legally truthful, and coherent set of conjectures and understandings of the way federal finance is done. It's it, period, full stop. And so whether they disagree with me or not, their careers are paid to be in disagreement with me because they've written for the last 40 years lies and propaganda and tons of books, garbage, trash, that has killed more people, that has created austerity, has created sound finance, that has murdered more people on the lower end of the spectrum than any war we've ever had. So if you want to hearken over to those other people, be my guest, but I put you in the camp with those murderers. That's the deal. The fact is that economics is a tool of murder or it is a tool of life. It is ultimately a way of distributing real resources. And if you're holding back with lies about scarcity and pay-fors, then you are a murderer by policy. You are a murderer by social inequity. You are a social murderer. And there's a study in London that shows that austerity is murder. I've been saying it's my tagline on Twitter, and I'm not afraid to say it. People that advance the scarcity narrative, this idea of taxation and funding, literally are playing into a murderous paradigm that specifically makes the money to be the scarce thing instead of the real resource. You can disagree with me, but I'll go toe-to-toe with anyone. National stage, public, I don't care. Anywhere you go, bring it. I got it.
And I think that's, that everyone, please stay tuned for our next panel, because people need to understand MMT isn't something that needs to be implemented. It's something that literally already exists. It's already here. It's how we work. It's just getting people to understand, how money works in actuality.
So can I interject, Joy?
Sure.
Can I just interject something to respond to Steve? And that is, so Margaret Flowers once wrote that the problem at the federal level is not the ability to fund programs; it is the political will to fund them. And I really do agree with Margaret there.
She is 100% right.
Yeah, and man, I mean, unfortunately, she's dealing with some personal things, and we wanted her on this panel so bad. So love to you, Margaret. You're amazing. You're inspiring. We will talk to you anytime. And please follow her to learn her thoughts on state by state, because she as well, brings up some really great points. Unfortunately, this panel could be 5 hours, and I know I've been saying that literally every panel all weekend, but I want to go around and give everyone last thoughts, where people can find you, if you have anything to promote, anything like that. So we'll go around in the circle again. Miss Kay.
Oh dear. Well, if you want to see the unions that have endorsed national single payer, you can go to unionsforsinglepayer.org. And I am also active in the Kentuckians for Single Payer Healthcare, which is our state group. We do have a state group, and our state group here in Kentucky pushes for the national bill. We have no thoughts that we might be able to win this in Kentucky. We've got to win it for the nation. So that's kyhealthcare.org. And we appreciate anything people can do. Come see us on our website.
Awesome. You're wonderful, Kay. Thank you so much for joining. Dr. Malinow.
Well, first of all, it's been a real pleasure to be on this panel. I learned a lot from Steve. I have to say that my understanding of MMT is minimal at best, but I'm very willing to learn and know more about it. So thank you for teaching me all of that. I just want to say that again, that healthcare is a human right, and it is a national responsibility. It cannot be left up to the states. We are given this incredible opportunity right now. This is a crisis moment, and we really should not squander it. So it is our moment to rise up and demand healthcare as a human right. I believe that we do need a bold, beautiful model national bill, and I hope that the activists in this call are going to help us write that, and then find a congressional co-sponsor or sponsor to introduce it. I think that at that point, we can have all activists in every state use it to achieve national single payer improved and expanded Medicare-for-all. And for more information, you can go to our website, which is nationalsinglepayer.com. Thank you.
Thank you so much. And Steve.
So the big thing for me is understanding how to resource, to prep the runway for all of these plans that we have. It doesn't happen when we pass the bill. We've got to get ahead of this. We need to understand that in order to have enough doctors and enough nurses and enough all the other services, buildings, clinics, you name it, there has got to be prep work done. These are things that take years to develop. Doctors, and we may have to import people. We may have to bring in immigrants to serve in these roles because we don't have enough in this country right now to take care of everyone. So it's important that we figure out what the real resources are and build plans around that. irrespective of cost, and really begin to make that case and realize the tie-ins with the Green New Deal, a job guarantee, and all the other aspects of Medicare for all, that it's not an island, it's not orphan politics, it's literally a part of a whole, it's a part of an ecosystem we need to build for everyone. Now, as far as where you can find me, I'm on Twitter at Austerity is Murder. You can find me SD Grumbine. I'm also the founder and CEO of Real Progressives and Real Progress in Action. Find us at our website, realprogressives.org. And of course, go to our YouTube channels and so forth. And my podcast, which I think is must listen to if you want to learn MMT and all the adjacent aspects of it, is called Macro and Cheese, and you can find it on any podcast platform.
Awesome. Well, much love to all three of you. And Kay and Anna, thank you so much for helping to organize this event as well. There are so many other people who, are behind the screen and things like that as well, that it took many of us to bring this together. And just thank all three of you so much. And I think to sum it all up, I think so many important points were made during this panel. But I think to sum it up is, if everyone who says they support Medicare for all pushed for national as a priority, as the number one thing, not just, well, I support that, but as a number one, talk about that the most, push that the most, get petitions for that the most, fight for that the most. If we all did that, you would see an uprising. People would say, well, it's not going to happen. That's because you're focusing on incrementalism. Just like Kay said, don't be defeatist. Don't say, well, it's not going to pass that way. Well, if all y'all stop pushing and human protest and fight for national, we have a much better chance. So if you take anything away from this, just take the fact that national should be our priority, whether you support state by state or not. Focus on national. So thank you all so much. Again, much love to all three of you.